Welcome back, everyone. Dan Soffer here at the NLA Scientific Sessions, having a chance to sit down with our poster award winner, Josh Hyman. Josh, welcome to the sessions. I can't wait to hear about the poster prize. You've done some great work. Why don't you tell us who you are?
Yep.
Tell us where you come from. Tell us what brought you here, and tell us about your poster.
So first off, thank you so much for having me on the podcast. I'm really excited to be here. Once again, I'm Josh Hyman. I'm a current third-year resident in the Combined Internal Medicine and Pediatrics residency program at Yale. I'm originally from New Rochelle, New York. As far as getting interested in this work in lipidology and preventive cardiology, it probably started based on some experiences I had in my first few years of residency. I'd be working in the adult emergency department or the general cardiology floor or the cardiac ICU, and I'd be seeing all these young patients coming in with cardiac events. And I was wondering, how can we identify these people early so that we don't have a 35-year-old here with cardiac arrest? And so I kind of got to thinking, that's a question that hasn't really been answered. Namely, how do we find young and middle-aged adults who are at high lifetime risk of cardiovascular disease pre-event? So there are a few issues with this dilemma. Number one, many of these patients, as we're all well aware, are not super well connected to the medical system. Many of them either don't have a primary care provider, or they do have one that they only see on a very rare basis. Maybe it goes years between the time of one visit and the next. Additionally, a lot of the medical care that folks in this demographic do get is kind of an acute visit to an urgent care clinic or an emergency department, and then they disappear into the ether, not to be found again. So that's one issue. Another issue is that when you talk about young and middle-aged adults writ large, this is an incredibly heterogeneous population, right? They live in different places, they work in different places, they go to different houses of worship, they shop in different places. And so the idea of finding a singular place or a singular, common thread among this heterogeneous population seems daunting, if not impossible. But then I kind of stepped into the pediatrician portion of my brain, and I said, well, what do these people have in common? And it occurred to me that many of them, most of them, in fact, are parents. And so the data bears that out. So specifically, 75 to 85% of adults in the United States who are 49 years of age or younger have had at least one biological child. And so then I started to think, well, what could we learn about the health of the parents through the child? And how can we use a child as a window into the metabolic health of their parents? So that kind of lays the groundwork for my research project, and I'm happy to tell you more about that.
Well, Josh, you realize, of course, that is completely backwards from the way that everyone has taught us how to practice medicine. Mm-hmm. And what an interesting way to dive into health and disease. Of course, it makes perfect sense. We don't have access to that 35-year-old when they were 25 years ago as a child. But we have something pretty close to it, don't we? We have their progeny, and that's a great way to
And just to circle back to the value of looking for cardiometabolic health screening in children interface with the healthcare system more frequently than adults. They have more touch points, so there's scheduled immunizations, there are well child checks, there are school forms, and kids get sick often. How frequently, it feels like every few weeks or a few months, a kid's coming in for some sore throat or earache or some new cough. And each one of those interactions with the healthcare system, they're accompanied by a caregiver, an adult caregiver. And that is an opportunity that is missed to do cardiometabolic screening, or at least to think about, writ large, what is the health status of the family that you're dealing with.
Yeah, I totally agree. I served in primary care for 27 years of my career, and sometimes I'd see a middle-aged person come in for their sore elbow, of which I know virtually nothing, but they have a cigarette pack in their pocket.
Yeah.
And I saw, now there's an opportunity I can help them. I can't really help them too much with their sore elbow. I can point them in the right direction, but I do know what I can do for that person who's a middle-aged person smoking cigarettes. So great opportunity to think about the care of the health of that individual down the road and of the care of their family members. So why don't you give us an overview of the poster you presented.
Yeah, so the poster title is a Universal Lipoprotein Screening of Youth and Reverse Cascade Screening at a Primary Care Clinic. So it's a bit of a mouthful, but just to briefly review lipoprotein A for our listeners, this is a highly atherogenic, independent causal risk factor for cardiovascular disease. It's highly prevalent in the population, estimated that 1 in 5 individuals has an elevated level. It's highly heritable, and it's highly stable, which means that it's thought that you achieve your adult mature level of lipoprotein A after approximately the age of 5, and it stays more or less the same for the rest of your life. So all these attributes make lipoprotein A very interesting biomarker to consider testing in children. And so that's what we did. Current recommendations from the American Academy of Pediatrics and others recommend universal lipid screening, so standard lipid screening in children aged 9 to 11 years old, and that's primarily to detect primary dyslipidemias, namely familial hypercholesterolemia. There is not a lot of data one way or the other on lipoprotein A screening in children, but what the guidelines do say, if and when they speak about it, is, well, we recommend selective screening in kids who are high risk. So we just took a different approach. We said, well, what if we add on a lipoprotein A measure to the universal lipid screen that kids should be getting anyway? And that's exactly what we did. So our inclusion criteria was any 9 to 11-year-old who walked into our clinic and was seen by a resident physician. And we ultimately had 37 kids who underwent testing. Of that, 10 children were found to have elevated lipoprotein A, coming out to approximately 27%. And this was not surprising because this is, like I mentioned before, around the general prevalence in the population at large. We also asked all the children, before they were screened for their lipids, those selective screening questions to determine if they would be deemed high risk and eligible for lipoprotein A screening under the current, regime. And interestingly, of the 10 children who had elevated lipoprotein A, a whopper big 0 had any high-risk features that would have justified selective screening. So the main takeaway there is that if you do selective LPA screening in kids, you're going to miss the vast majority of the high-risk individuals, which is what we'd anticipate based on what we already know about screening in adults.
Albeit a small population. So
yes.
maybe too broad a conclusion from that, but I get your point.
Yes.
That makes a lot of sense.
And then as far as reverse cascade screening, we offered cascade screening to the siblings and parents of our probans who had elevated lipoprotein A. And so we had 12 first-degree family members who underwent testing, and of that, 2 out of every 3 also had an elevated lipoprotein A. This is also in line with our expectations, given what we know about the high heritability of lipoprotein A. So some big takeaways from all this. Number 1, elevated lipoprotein A appears to be prevalent in the pediatric population, which would conform with what we know about it in the general population. Additionally, reverse cascade screening has a high chance of detecting other family members who may also have elevated lipoprotein A. And that pediatric LPA measurement can be a potential useful tool to identify entire families at high lifetime risk of cardiovascular disease. So those are kind of my main takeaways. I did this all out of a primary care clinic, no funding, just me, kind of bootstrapped it. And I think that in itself is kind of a lesson that not everything needs to be done through funding or, some fancy protocol. Sometimes you can just do good care for patients with what you have.
Josh, that is fantastic. There's so many great take-home points. So you highlighted all of them. And that last point about just being able to create a little microcosm of what you can do. And this is clearly something that could be done at scale in larger populations. There's a lot of mechanical issues that could be sorted out really in a very cost-efficient, safe manner. And I don't think there's a lot that would get in the way of that. It's just a matter of if there's a will, then I think we can find a way to screen our children. It makes sense to screen our children, especially if the results we find are going to carry through for their entire life, identify who has this additional risk factor for heart disease, and then be able to then screen the rest of their family. ultimately, we'd love to just check LPA in every single person in the population, but sometimes you have to start with these smaller populations.
And one last little thing about what's the benefit of screening in kids, specifically to the parents, because that's how I started, right? You're trying to find these young and middle-aged adults. So the average age of a first-time mom or dad in this country is between 25 to 30 years old. So if you just iterate it out to their 10-year-old daughter going in for her lipid screening, mom and dad are between 35 and 40 years old. That is the perfect time to identify an adult who's at high lifetime risk of cardiovascular disease. They likely are still pre-event, but they likely have a milieu of cardiovascular risk factors that we can intervene upon today in that moment that'll hopefully keep them healthy in the long term. So part of the benefit of pediatric lipid screening is actually to identify parents when they're relatively young before they end up in the emergency department or the CCU or the general cardiology floor.
Great points, Josh. Thank you so much.
Thank
what a
you.
wonderful discussion.
It was a pleasure.
You're a rising star. I can't wait to see all the work that comes out of you over the rest of your career.
Thank you so much.
Thank you.
It was a
Thanks
pleasure.
everyone for being at the NLA Scientific Sessions. Great opportunity for learning and from our experienced and early career investigators. So thanks again.